At this point, what I'd like to do with the remaining time we have is invite all of our presenters to come back up here and field some questions during this brief window if we can. I think that Jane and Mariah are going to take point on most of that. But what I wanted to just briefly do while we have the opportunity, folks, is we had mentioned in our email that we wanted to have a little chance if anybody had brought a success of something that you've implemented in your workspace that you find to be really, really beneficial in terms of a change, something you've tried out to help affect the transitions process, that you wanted to share that. This is a time that we can do that. Is there anybody who went, whoa, story time, I know I've got to share this. This is let's take a couple of minutes and do that before we do our open Q&A.
Hi everyone. My name is Brenda. I'm from Virginia Garcia, as I mentioned earlier. We work at the Hillsborough location, and we have a transitions of care program that we run out of the Hillsborough clinic. Really briefly, what we do is we use pre-manage to find out where our patients are. We do outreach at the hospitals, try to get them into the clinic within the first week, and they see a whole team. They see an MD, a PA, a clinical pharmacist, a social worker, Kendra, who's right here, an occupational therapist, yes, and we also have a care coordinator on the team that manages, so they see this whole team, and then we do a 30-day really intense follow-up. One of the things that we find most successful with how we run our program is basically the intense stalking that we do of our patients over that 30 days. Because, a lot of the barriers that our patients face in accessing healthcare at our clinic or, accessing our services, they face those same barriers in accessing those services anywhere. And so, a lot of our patients need to go to dialysis, or they're homeless, or they're this or that. And, we're not just coordinating for us, we're coordinating for them to access those services in the community. And we're really seeing really great results in keeping them out of the hospital just because they're really engaged with us. They feel like they have a connection with us. And, with having clinical pharmacy and all of these great services on the front end, really help them orient themselves as they're leaving the hospital. But then, over that month-long period, we're just really able to address some bigger issues that they face. And just really quickly, another thing, one of our presenters had mentioned data collection. It's been a huge pain for us to, do any sort of process improvement, because extracting data for the patients that we see and also patients that we don't see to have some sort of a control is really difficult with the way that our EHR system is. Things are just free text notes. And so we're having to do it all manually on Excel, which is horrible. And so we're actually working with Ochin to develop some really great tools to be able to help us not just with our transitions of care patients, but all of our patients, just really quick ways to extract the kind of information that we would need to make those improvements over time.
Awesome. Please do, of course.
And just like a shout out to everybody in the room, really, because it does truly take a village. So I think something that's been really successful for us is developing those relationships across all of these systems. So knowing who, getting in touch with the care management departments at the hospitals, coordinating internally with the folks at CareOregon that have the transitions program. So, when we know who's doing the work and can make those connections, it just facilitates that process, because at the end of the day, they will be coming back to us at the primary care level, ideally. So thankful for that. And with the SNFs, too, that's something that we've been trying to focus on a lot more. So we know they go from hospital to SNF and then initiating that outreach to the skilled facility and doing that same kind of assessment and workup to support the transition from SNF back to primary care, just like hospital back to. So thanks.
Okay, thank you. I'm going to pass this back over to Jane here, and we'll just kind of open up during the time that we have, either for questions, more sharing, more I have a huge need that I collectively feel we all do, and we'll just kind of roll with the time we have left.
I'm wondering for our SNF presenter.
Meryl, hi. Ooh.
What do you know about assisted living and post-acute care life? I think you could frame those as well, because from my understanding, they don't even have a requirement to have a nurse on site. So please tell me I'm wrong.
Sure. So post-acute is a broad umbrella for really that gap between anything that is below hospital and not primary care. So it's a huge umbrella, just that term post-acute, and it can mean different things depending on what state you're in, et cetera. I don't work very closely with our assisted living side, so I don't know that much, but yes, they have very different requirements. That is someone's home, and so it really changes. You can have home health coming in to visit somebody, and I would recommend that as often as possible. Do we have?
I know a little bit about
Go,
assisted
Jane.
living, because I did a stint in the skilled and ICF and RCF and independent living environments. And assisted living is, it's a range, right? Some people are almost completely independent, do their own meds, take care of themselves, fix their own meals, et cetera. Or they may need some daily assistance, maybe somebody coming in and giving them their meds, helping them with ADLs, et cetera. But they're not required to have 24/7 nursing. And so they are CNAs that are given some extra training to be able to pass medications, and they're basically there. And then I think I don't even know what the regulation is, but it's just some oversight by a nurse periodically.
It's like
It's like once a week, or maybe.
and then every 30 or 6, I remember there's like an actual assessment.
Jan knows everything.
I don't know everything because I haven't reread the rules really recently, but so assisted living is a form of long-term care like adult foster homes and residential care, and also what's called intermediate care in nursing facilities, which is ongoing care for chronic conditions in a nursing facility. They're all licensed by the state, and they have very, very rigorous regulations to meet in terms of staffing ratios and things. Of all the types, assisted living, often, I'm not quite sure how much nursing is required, but most of them have some nursing available. And it is to train staff primarily and do delegation reviews on the things the staff are delegated to do, rather than to provide direct nursing care. So it's a different nursing role in assisted living. And adult foster homes and residential care don't typically have nurses because they're considered settings where you're getting care with your ADLs, your activities of daily living functional needs, are not medical facilities. Okay. Does that help?
Yeah, so I think.
Thank you.
Oh, no.
That's correct. No, and in fact, some residents there use like our house call providers, so the providers may go to them, or they need transportation out to their own primary care. And I think Meryl's correct. Those are settings where you'd want to order home health if they need some sort of level of nursing care for a bit.
Do you see that as like if you were to do a SWOT analysis? I think about these mobile health clinics and home medicine outreach. I see some PAs and FNPs moving into that, but I still identify that as more for people who have insurance or can afford to pay. Is it actually a covered benefit for our Medicaid patients?
For like house call providers, absolutely. They are primary care in the home.
But as far as like being placed at an ALF, like a lot of times it is private pay. So I actually did some research on this during my grad school thing. They were actually created here in Oregon, and they're specifically not regulated as much in order to give people the freedom to build a program that serves the population that they're trying to serve, right? So each ALF has its own like kind of target population, if you will. You know, so they all work differently, and that's very intentional. The unfortunate downside is that they do have that kind of barrier of privilege where you do have to generally private pay for them. Some of them do have like Medicaid beds that are funded, but for the most part they are private pay. They're very different, just ALF to ALF. So.
Well, and I don't know how many of you are familiar with house call providers. It is now a part of CareOregon. I'll just say that. But it is primary care, in-home primary care, which is, you know, something that as you consider your patients that are increasingly have increasing difficulty going out to access care, or have you become homebound, that's a really good referral for primary care.
Pass this over here to you.
Is there a state organization that's tracking all of these projects? If you're doing this every day, you could learn about all the resources that are in development.
My answer, I have an answer.
Kind of in which topic? On all the, sorry, you mean all the different home settings?
Care management and care transitions. It feels like you have to go out and piecemeal put this together. Oh, I heard about C-Train a couple of years ago, or today I'm learning about beds to med, you know, or meds to bed.
Right.
But there should be a website where I can keep up on the news.
I think Dan was trying to say, what I would say is, I would have Jan speak to that.
Well, that's a really good idea, but we do have this transitions work group where we're trying to bring people together from across all the spectrums to work together on, you know, consolidating information and being an information hub about transitions. I think that's actually an excellent suggestion, and we haven't started trying to build any kind of matrix of everything that's going on yet. I can hardly keep up with it. I try to go to every meeting I can related to transitions and try to help communicate. But we invite more people to join us in this work. We're having some very robust discussions about this issue of workflows for those of us using pre-manage. We find that we don't all see the same thing when we're looking at pre-manage, and we don't always, it's harder to communicate and collaborate than you might think, so we have to do some work on workflows and communication to make that work for everyone. So we're talking about that across all these systems. We're talking about things like the whole how to deal with folks who are houseless and you know, work with 3 counties who have 3 different systems for coordinated homeless access and figure out how we can all work together better on that and getting people into the system faster, so because there's not enough resources, so it takes time for them to percolate up higher on the list and have access to housing. So we need to get started on that earlier in the process with everybody. We're also working on issues around folks that need medical assisted treatment for substance abuse and trying to smooth out some of those wrinkles. There are, you know, a lot of topics, but anyway, invite anybody to join us in the work, and we're having a meeting coming up next week on the 14th at Mount Hood Medical Center from 8:30 to 10:30 in their boardroom, and it's a big room, so you can come. And then we're meeting monthly and trying to identify issues, strategize solutions, bring the solutions up to our respective systems, and try to get some coordinated action going.
In some ways, we are our worst enemy. You know, we have electronic health records now across the spectrum, but we don't share. Part of the intent of going to electric health records was that there would be continuity of care and patient access to information wherever you went for your care, and we don't allow anybody to look at our records. And you know, mental health. I think you mentioned earlier, mental health is here and physical health is here, and we don't we don't share systems and talk. So we've kind of created our own barriers, and I think we need to start working and being much more proactive and collaborative to try to now get to what the real dream is that we have, the ability to truly share across the spectrum. Because I, as an individual, as a patient, want to be able to, wherever I go, that you can see what my history is and what my situation is, because that's real patient safety. So
Sprint back here. I know we got a couple of people.
Quick question: would CareOregon, just speaking to the question earlier, would CareOregon invest in some sort of registry or something for all these different transitions programs that are in the community, so that we can all kind of see what's going on, and if we could, like, for example, I feel like I just learned so much in the last few hours, and I'm willing to, reach out to some of you so that I can learn more about, the obstacles you face and how you run your programs and so on. So is that something that CareOregon would look into developing?
we actually had started down that road a couple of years ago as we were developing more transitional programs. Like Jan was alluding to, it's exploded. So it's really hard because every day there's something new and something else happening. But I agree, there needs to be some sort of centralized place. Somebody mentioned, I think it was you maybe, talking about, having to call 5 different people to see who's really the most engaged or needs to know this or is taking the lead on this for this care coordination and transition. That's cumbersome. It can be duplicative. It can be frustrating. On the flip side of it is we're doing it, and 5 years ago people weren't helping helping patients transition in care. So in a way, we're falling all over each other, but we're also in a really strong learning curve, and I think this business. This care coordination model is new. It's it's about 5 years old, and so I think we're hitting our stride where everybody stumbled around trying to figure things out, and now we're coming together and doing sharing. And so I think we're getting there. I think there's a way to go, but. The more we collaborate, the less we have turf issues, the more we're willing to share and work together, I think that the better we'll get there.
One comment to that, Jane, is that I think we're also recognizing that there's actual fatigue on the part of the consumer in all of our efforts. And so we're actually beginning to recognize that collaboration is just necessary not only for the labor part of it on our end, but also just for the rapport and the engagement, the receptivity that the consumer has. After a while, when they've had their 3rd phone call, even from CareOregon, it's like, from a different program.
It's true. Well, and I'll just say too that regulatory standards don't help. And,
We just got rid of HIPAA.
I know there's good reason for some of them, but Meryl alluded to how regulated skilled nursing facilities are. To where it impairs your ability sometimes to really do the right thing, and sometimes the reason CareOregon members can get multiple phone calls from people for a transition is because hospitals are required to do a transition outreach, clinics are being expected to do that. For our Medicare population, we're required to do that. And so, some of that is because of regulation and makes us unable to kind of, coordinate that better. Yeah.
I'm going to get on my social justice soapbox for just a minute about that. I think just so everybody thinks about, just give them something to chew on, is we all work in this system that was created by educated white males, like the whole healthcare system, right? So we come at our work, or the system comes at people with that paternalistic viewpoint. And so we're always trying to assert what we think is the best thing for these people all the time. And it's out of a place of love. I get it. Like, you know, we're trying to help people. But we also have to recognize that that paradigm does not work for a section of our population, a significant section, whether they hold, you know, whatever intersectionalities they hold and vulnerabilities they hold, whether it's language, whether it's gender identity, whether it's, you know, whatever. So just remember that the people that we're working with, we're constantly trying to push our paradigm on them. And to really sit with them and to create plans and things that work, we really do need their buy-in, and that means that they have to have some efficacy and ownership in the programs that we create. So, all right, get down. I'm done.
Mai?
Can I make one last comment? One of the other thing that Anthony and I run into during our projects is that the resource available at each hospital and each clinic is very different, even within our own system, like pick Legacy. Legacy Emmanuel started this project with CareOregon. They also have at each of their major hospital a transition of care pharmacist. However, their role and function is very different. I trying to work with Legacy Good Semm, transition of care pharmacist, but her focus is ED, and so we couldn't really, you know, work on like the inpatient hospitalizations, and then. One of the example you gave was like Meridian Park, you know, with SNF. So even within one health system, there's various programs for transition of care. And so I think the resource is there, but even within our organization, we don't even know, like, do you know who to get a hold of at the next hospital? I mean, it's not even transparency. And so I think it's good that we sharing resource, but I think also recognize that there is barrier within our own health system. Because you mentioned VG Hillsborough have a transition of care team, but other VG may not have it. And so, and you know, even if they do have some sort of support, it's different. And I know
like acknowledge that the relationships would be unique because all of us are in different geographic locations, so it'll be unique to the hospital that we work with. Yeah. And so that's actually built in and intentional. But it's true. We have resources within our clinic that are only for CareOregon patients, and we serve a much broader population. But those people can only do work for that, and that for me is an equity question that I always is a challenge.
I agree. So I think it's good that we're sharing, and maybe we can think of a way how to systematically update on the resource. But I think we also need to work within our own organizations on how to kind of collaborate better or share information better.
And I think on that note, we're going to have to release these folks back into the wild. So a couple things real quickly, folks. I want to thank you all for being so participatory here today. Everyone had so many good questions and a lot to contribute, and thanks for being generous with your time and interest. Would you help me out by just giving a huge round of appreciative applause to our amazing presenters here today? We got really, really lucky with this one.